Hey, welcome back to Basically ALS. Have same crew as last time, I think. Some real studs on the panel today. If you guys want to introduce yourselves real quick.
Go ahead, Mustache.
Hey, I'm Mike. Been an EMS instructor for 6 years. Been an EMS in general since 2016, and most of that as a paramedic, and been a flight paramedic for the last almost 3 years now.
Hey guys, Casey Lane, medic for 14 years roughly, field for 17 since 2008. Been a flight medic now for almost 4.
I'm Wade. You guys know me
everyone
by
knows
now.
Wade. Yeah,
Everybody knows Wade.
hopefully. Real quick too, some housekeeping stuff. We started the new channel. If you're not aware, we have a Basically EMS specific YouTube channel. So if you are watching this on the Summit channel, we're not going to be posting on the Summit channel with Basically EMS at least for very much longer. So we'll put the link in here. Make sure you go check out the Basically EMS YouTube channel, subscribe over there so you don't miss any episodes coming out. But I don't know, Sabrina and I haven't decided exactly this episode, maybe one more we'll post on the Summit, and then we aren't going to be posting these onto the Summit Healthcare Education channel anymore. So make sure you're checking out there. And if you're listening just to the audio only version, we do have video versions if you want to go check those out. So, all right. Today we are going to be talking about some chest trauma stuff. So we were kind of hesitant to talk about trauma a little bit because, I mean, trauma is pretty basic. Going from the BLS to the ALS level, there's not huge differences, at least in kind of the mechanism of everything and how it all works. But treatments are where we start to really differentiate. So we'll kind of dive into that a little bit. So as always, I think maybe talk a little bit about the anatomy of the chest. Anybody want to kind of jump in, talk about maybe the great vessels or kind of jump in there? How about Wade?
Yeah, I can jump in.
Go for it.
Yeah, so thoracic cavity, right? So we're talking rib cage or chest cavity. It's going to be 12 pairs of ribs stemming from your 12 thoracic vertebrae, which is why it's your thoracic cavity, with the last set being floating ribs, which we'll talk about. Those can be pretty problematic, especially in high trauma situations or high mechanism situations. Big part of it's going to help us breathe, right? So our intercostal muscles, from just a structural outside of the wall, helps our chest expand. But the big thing is the stuff inside, right? So the great vessels being your aorta, your vena cava, and then you're going to have, obviously the heart, lungs, esophagus, trachea, different portions. And then if we're going to get even more particular, the mediastinum or mediastinum, however you want to say it, that middle line right down the chest, right? So you got your heart, great vessels, lungs are excluded from that list, right? Remember, they're on the left and right. We're only talking the middle. But that mediastinum is where we can start having issues, right? When that starts shifting, that's when we start looking into things like tension pneumos start showing up, which we'll talk about here in a bit. But, that's just a potential out of the situational stuff, right? Depending on what happens, how you get hit, you start having some changes.
Yeah, I think one thing to add to when we're talking about the anatomy of the chest is going to be the pleura, because they're essentially, I think of it as like throwing lungs in a garbage bag, essentially, right? And we're going to have this covering around our organs, and so there's 2 different sides. There's a visceral pleura and the parietal pleura, visceral to the organs, and then parietal out to the body. But that's where we can start to have some issues with blood being trapped in there and that kind of thing.
Right.
And then similar to that around the heart, we have the pericardial sac, and so we can have blood trapped in there as well. So it's important to remember that, we have organs in there. They have these coverings so that there's, less friction as they're moving, because they're moving inside the chest. And there's some fluid in between those layers so that it moves smoothly, and those layers are there for a reason, but they can cause issues in chest trauma. And so when we talk about a couple specific types of chest trauma, we need to make sure we're aware of those structures, because they're going to come to play in there.
Right, the supporting structures.
I think that's a good point. And I think a lot of people, will kind of either forget or just neglect some of those pleural layers. Those really are what come into play, especially when you're doing treatments. It's a lot of people think of the balloon or the lungs as just a big balloon. They're more of a sponge than a balloon, that are in a pillowcase or a garbage sack, right, of a layer. So
maybe your body's a pillowcase. Mine's more a garbage sack.
But yeah, I think a lot of people kind of either disregard or forget some of the specifics, and although they're small things, semantics, if you will, they do come into play, especially when you start getting higher up.
Yeah, and I think that's something that I know for me personally. Like, you learn all this stuff in EMT school, you go become an EMT for a couple years, and then you're like, I got it. But this is the stuff that you forget. You forget these little things, like, as we, having been a preceptor, and I think you guys maybe both have been preceptors through the same place, right? Like, you have this, this little lecture with the program director before, and he has this talk about, experience versus knowledge, and how, students have this high level knowledge with no experience, and the preceptors have this high level of experience and their knowledge has kind of dropped, right? And it's finding that balance in between. And I think that the same can be said of EMTs and the paramedics.
100%.
And so when you go into paramedic school, that knowledge is kind of lost. And I feel like this is kind of what's lost. And you've made up for it with experience. So you still operate better than a new EMT or a new medic if it's a medic, but you do start to lose these things. And I know for me personally, that was one of the things I was really happy about becoming an EMS instructor, is all these little things, even at the EMT level as a paramedic teaching. I'm like, oh, I forgot about this, or I forgot about those things. And it really helps you to, really be well-rounded and have a true understanding of what you're doing, and no cookbook medicine, right? If you really understand it.
Yep.
Yeah, if you want to take that next step forward, you need to understand the why behind what you're doing. And so you can go out to the field and you know what you're doing. You see this, you do that, but we really want to harp on the why. And so especially when you progress from EMT to paramedic to flight, whatever, it's knowing the why. And I think on the last episode, we kind of had a similar conversation, but that becomes very important when you're talking about these treatments and when to do it, when not to do it. You have to understand the why.
Yeah, and I think that's what separates a good medic from a bad medic, or not even bad medic, a good medic from an average medic. Because anybody can, you could give a monkey a book and say, like, when X and Y happen, you do Z, and anyone can do that and be taught to read an EKG or listen to lung sounds. But it's really the people that understand, like, what those lung sounds mean and why we're doing the treatments in that book, that's where you start to progress and where we start to have good medicine. Right?
Definitely.
Being able to deviate from black and white algorithm.
Yeah.
Because medicine has never been black and white, nor will it ever be.
No, yeah. And I think, for any, like, a student listening to this, if you're not excited to be in the gray, then maybe this isn't the right job for you, right?
100%.
Where it's fun.
Yeah. And maybe not at first.
Right.
The first 3 years, I know for me, anytime the tones dropped, I was like, man, I don't know if I'm allowed, like, who let me do this? You know what I mean? Like,
I need an adult.
Yeah, exactly. And then you start to kind of get that easy black and white stuff down pretty well. Yeah. And then you start to have, like, my favorite calls were the ones that, like, me and Mike would walk out of the hospital after dropping off and be like, dude, I have no idea what's going on.
Absolutely.
Let's call back in an hour and see what labs looked like. Or maybe like, hey, you think the doctor will talk to us real quick right now? And, like, run our theories by them and see if they're thinking the same things. And, like, once the easy stuff gets easy, then this is where you live if you really enjoy this kind of stuff.
100%. I loved the gray calls where you'd walk out, no one knows what happened. You go, well, that could have sucked. Like, that was my favorite moment.
Yeah. They didn't die, so we did our job.
Yeah, good enough.
They're not more dead than when we met them.
Yes.
But I don't know what we did, or
Figure it out.
Yeah, for sure. And unfortunately, trauma doesn't lend itself to that quite as well as medical, as we're talking about a trauma situation. But I think, learn the whys, learn what we're doing, why we're doing it, and your world just expands so much. And then you can live in the gray, or you can have that time where, like, oh, there's this thing, like, I'm going to not do that, especially not doing treatments. I think knowing the whys is really going to help you to not do treatments, because when they could be detrimental.
Right. In anticipation, right? You know when to do something, when not to do something, which is so hard the first couple of years because you want to do it all. But then knowing, okay, I'm not going to do this yet. And then understanding where, okay, I need to set up for this. So when it does come to that time, you're ready, but knowing when to do something, when not to do something, and then when to potentially do something and be ready for it, I think is where that why comes from.
Yeah. Yeah. And if you're new listening to this, you're going to make a lot of mistakes in that realm.
Still make a lot of mistakes
of that, but
learn from them.
Yeah.
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 Failure is where we learn best.
For sure.
It sucks, but it's true.
Yeah. Yeah. And if you're not ready to fail, again, this is not the right job for you, because you're going to fail.
I always told my students and my trainees, fail forward.
Yeah.
Don't be like me.
Learn from my mistakes so you don't have to make them. Yeah.
That's the true definition of wisdom, I think, is learning from other people's mistakes, right?
Yes.
So, let's get back on track a little bit.
All right.
So chest trauma, assessment of chest trauma. Who wants to kind of jump in about just some basic overview of assessment for chest trauma? The flight boys.
I can do it. I mean, a basic, and then I'm sure you'll have stuff to add on to. But I think in general, so it starts really with the scene itself, right? What kind of trauma are we talking about? Are we talking about, a multi-vehicle car accident? Are we talking about, gunshots, stabbings, penetrating versus blunt trauma? So you kind of have to somewhat know what you're going into. But in general, when you get your patient in front of you, it's that primary assessment, ruling out those life threats right away, right? So that doesn't change from the BLS to the ALS to the flight level at all. You need to control any obvious hemorrhage right away. And then after you've done that, we're going to start specifically focusing on the chest itself, right? So you need to expose that chest, right? So knowing if you have a gunshot wound, right, you need to expose the front and the back, make sure you're not missing anything right away. That has to be done very early. I think we see it when we test off students. They fail to do that fairly often. So inspecting the chest first, and then it's going to be palpating, and auscultation is kind of the real basic ways to assess the chest, right? So first off, exposing and inspecting, so getting a visual inspection from their chest and their abdomen, really on the front, and then as well on the back, so to see what you're seeing, to see what you're, if there's any obvious injuries you're looking for, equal chest rise and fall, adequate respirations of rate, rhythm, and quality. Do you have any flail segments? Do you have any penetrating injuries or blunt type injuries? And then going to palpation, actually feel the chest, right? Do a good physical assessment. It's not enough to just look at the chest. You have to feel it. And usually what I do is I will take my hands on both sides of their rib cage, and it's not like I'm pressing in very hard, but I'm just feeling how they're breathing. And if they're conscious, have them take a nice deep breath, feel that equal chest rise and fall on both sides, really feeling for an adequate rate, rhythm, quality, right? But that crepitus, do you feel any lack of movement on one side or the other? Do you get blood on your gloves when you pull them away? Things like that. And then auscultation, right? Listen to those lung sounds if you have that major trauma, because you don't want to miss that pneumothorax before it's too late. And then if you do see any major injuries that you need to address right away, any life threats, address it. Things like the BLS treatments, occlusive dressings. And that's really what we're going to do at that point. If you need to go down that route of ALS with the needle decompression, we're going to talk about later. But do your life-saving treatments right here and there. And so after that, it's really just a matter of kind of moving on and seeing what else you're gonna find, getting your vitals, getting your GCS, and sorry, need a little bit of water, but getting your vitals, getting your GCS, and kind of moving on from there. But that initial assessment needs to be quick. It needs to be very efficient. And you need to find those life threats. That's the most important thing. I think
a big thing, and you even touched on it, is that auscultating, palpating, inspecting is all very simple things, but that's what separates an EMT basic from a medic to a flight medic, is how well you do the simple things, right? And your technique of feeling and listening, or not listening, but feeling for when they're breathing, that's something that's it can be taught, but it's not really taught until you do it, right? And so that's the separating, Yeah. It's just one of those things to consider. Even though it's that's what we're limited to. But if you can do it well, it'll give you a lot more answers. And then you'll kind of learn just from watching and hearing other people do these things.
Look, listen, and feel, right? And that comes from, the textbook can't teach you that you're going to walk onto this scene where people are screaming and yelling. There's cars going by. There's a lot of noise. You're in a crowded venue at a concert, or whatever the case may be. And you need to actually, it's like street assessment as opposed to that textbook assessment you pick up on that kind of thing through the years. So
that's where, all three of the look, listen, and feel components come into play, because in the environments that we operate in pretty regularly, it can be really, really hard to listen. It's hard to auscultate with a hissing radiator or in a bird or
a concert,
the fair.
I feel like there's a story there.
Yeah. So Garth Brooks came to town a few years back, and I was Mr. Mike was my mentor, and he's like, get a blood pressure. I was like, yeah. And I went to go and get a manual auscultated blood pressure.
Good luck.
Yeah. I learned very quickly I can't hear anything. And then he's like, yeah, just put the automated cuff on, dummy. It's like, oh.
I think it was like here.
Yeah. So I felt really stupid from that moment on.
Yeah, but like Casey was saying, right? Like the situation is gonna kind of dictate sometimes what we can do, and you need to be good at all different avenues because sometimes situationally we can't do one of our tools might be out of our toolbox at that time.
Right.
And I think a big part of that assessment is your initial treatments come within your initial assessment if it's a life threat. So don't be afraid to do something right away. It's not like, oh, there's a hole there, let's move on, right? It's we need to fix that right away. So having that confidence to have a really good assessment and then fix that life threat right there.
Yeah, that's I've heard and we've all been teaching for a long time, right? And I'm sure you guys have all heard so many times of like, oh, those NREMT sheets, that's not how you do it in real life. And at first I kind of felt that way until I started teaching, and then you realize like, no, dude, like really assessment, especially like
that primary.
The primary is important, and we teach so hard at the basic level of like, if there's a life threat, treat it in the primary. That's the whole purpose of the primary. And so I disagree that we move so far away from the national registry sheets. National registry sheets are like, make sure you're scene safe, do all your scene size up stuff, do your primary assessment and fix life threats, and then do your secondary and get your history. That's what we do realistically, right? And I know people don't like it because it's formulaic and basic, but
You got to start somewhere at the foundation.
You got to start somewhere, and I've never come up with a good. I always used to say I don't like it just because it's linear. Yeah, right. A dynamic scene is not necessarily going to permit you to be linear like that all the time. But to your point, it is foundational. It is what we do at the very root, and I don't, trying to think of a different way for the last 15 years, I can't.
No. Yeah, it's one of those, like, I think there's like a meme where there's like the new guy of, and then of like, we're learning this knowledge, and then like the middle experience of like, that's wrong. And then like the master's like back to like, no, that's right. And I feel like I had that journey of like, oh, this is how we're supposed to do it. And they're like, no, that sucks. I'm so much smarter than them. Yeah. And then having done it for like 10 or 15 years now, I'm like, no, that's the best way to do it.
Right. That 3 to 5 year range where you're like, nobody can tell me what to do. And then you get humbled hard.
Yeah, this job will do that real well.
I think a big disconnect too is that a lot of people, like from the field to class, it's so slow, right? Like we're breaking down something that realistically I walk in and I have all my information in less than a minute and a half, right? We have to break that down to 10 minutes. So they poo-poo on it because they're like, well, it's not realistic. It is. You just do everything a lot quicker because now it's visible. It's not
or a lot of things at the same time even.
Right. Yeah. And you got hands to delegate, and you can get a lot of information really quickly. And this is just a disconnect from the education realm to the field a little bit.
Yeah. One other thing I want to add to about the primary, what we're talking about here is like, that doesn't end after doing it once.
No.
And finding life threats, like I specifically remember I was on a call where a kid was shot. He was sitting in the front seat of the car. His cousin was playing with a handgun in the back seat of the car, and it went off and shot him through the seat in the back. And like my entire job, the entire transport, like 15, 20 minutes to the trauma center, I was listening to lung sounds pretty much consistently and just checking, making sure a pneuma was not starting to appear, right? Yeah. Because understanding the why, I know that even though we put the chest seal on, maybe something's going on, and we're anticipating what's going on, and we're assessing, knowing the why, we're assessing for the possibility of what could be happening, right? So I think it's important to remember, just because we've done a treatment or whatever, we still need to have these things in mind. Like reassessment, we teach reassessment and like every 5 minutes, and everyone's like, oh, another blood pressure every 5 minutes. Like, no, you need to be reassessing everything, especially our concerns. We need to really be looking back at that and looking at all these things Mike already talked about. We need to be doing that every 5 minutes. Put your hands back on the chest, auscultate the chest again. And especially if you see any changes in anything, start to auscultate and do your primary assessment again.
And I would add to the assessment part, and it kind of goes along with what you guys are saying about, we need to perform life-saving treatments as soon as possible, but putting your assessment together, I think, is kind of a big deal, right? Taking all this information and forming a picture, and really this might be oversimplifying trauma a little bit, but that doesn't make it any less true. trauma is all about air needs to move in and out, blood needs to go round and round, right? If you don't have one of those, then you need to address that. That is what we mean by life-saving intervention. If one of those two or both are not happening, that's what we need to fix right now.
Yeah, I like it. And yeah, at the end of the day, simplify things down to make it just easier.
Right.
You know, we can, especially when you're new, if you can break it down to those basic things and just keep those things in mind, especially, I feel like, especially like you were saying, you know, when you're new, you want to do everything. And sometimes you forget that that's the goal is we need to make sure that blood's going around and air's going in and out with oxygen in it, right?
That's it.
That's all that we're there to do at the end of the day. And we have a lot of cool tools that make us feel really smart. Like, oh, nurses can't intubate. We're so smart. We can intubate, right? Doesn't mean you need to do it. And so sometimes people forget that, like, that's our actual goal is to support the basic life functions. And sometimes we do that with basic treatments and not advanced treatments.
Yeah, notice how all that was, you know, basic scope of practice, right? You don't walk up with your ultrasound and like start, you know, doing all sorts of stuff. I know a lot of places are getting that now. It's very basic. So keep it as simple as possible, as complex as necessary. You know, you just got to start with the basics.
Yeah.
Kind of a sliding scale a little bit with that.
And I think to Casey's point too, of, you know, being able to synthesize all that information is definitely a learned skill.
Yeah.
And really, I think that's a big gap for somebody that's new, especially at the medic level, to somebody experienced, is being able to take all that information in. And I think a big part of it is being able to identify what's important and have that kind of there in your mind. Like I know when, you know, when I'm out in the field and I'm, you know, somebody's rattling off vital signs to me, I'm not hearing numbers. I'm hearing important or not important, right? Like, oh, that blood pressure is 86 over 40, important. Or versus, you know, SpO2 is 99% with, you know, good pleth, not important. I don't need to think about that. It's prioritizing in your mind what you're hearing. And that's definitely a learned skill. And it's really hard, but there is just synthesizing that, finding what you need to know, having that up front, and then the other stuff like, not super important.
Yeah,
it's 100%. Taking in multiple conversations at the same time while doing something and hearing those like trigger words that that you want and filtering out the rest. And that takes years.
Years.
Oh yeah, for sure. Yeah.
That's
So
where oversimplifying it or dumbing it down can help a lot.
Yeah.
Right? I'm getting all these pieces of information and it's just coming in one ear and out the other. Is air moving in and out? Is blood going round and round?
Yeah.
You know, especially in the trauma setting, where if you do have those, then maybe the goal is just to get to the surgeon.
Yeah.
You know, if I don't have a problem with either of those life-giving functions, then I don't need to do anything. I need to get to the trauma surgeon.
Yeah. Yeah. And what, based off my mechanism, what I'm seeing, what of those things could go wrong so that I can anticipate those going down the line.
Anticipation is key.
Yeah. If they're bleeding out, maybe blood's going around right now, but pretty soon it's going to be on the floor.
Or you can't see the blood, right? Because they're internal.
Yeah, exactly. Yeah. Lots of, you know.
Yeah, it's blood going in and out and there's air going round and around. That's not what
we can talk more about assessment, and maybe as we talk about more specific injuries, we can talk about more specific assessments for those. So, common chest injuries, we have kind of a list here, maybe just work our way down the list of like stuff that you can see. So Wade talked earlier about a flail chest.
Yeah.
And so, flail chest by definition is going to be 3 or more ribs, consecutive ribs broken in multiple spots. So essentially you have a floating piece of the rib cage, right? And I think this one I know is a little hard for me to understand at first, but if we think about the fact that we breathe with negative pressure ventilation, you know, that diaphragm is causing a vacuum in our chest, and our intercostal muscles are going out for sure, right? It's making our chest bigger, but for the most part, we're driven by the diaphragm. So that causes that negative pressure, that suction in within the chest. And so our chest wall is going out, but that disconnected piece, it's not connected to everything else, we're going to see going in. And so that's why we're going to see that paradoxal movement of that flail segment when somebody has one of those.
And then
paradoxical meaning that, paradoxical meaning that the, you know, that rib plate is moving opposite of the rest of the chest wall.
Yeah. Like, and to both your points, like the vacuum of our chest is still intact. So when you take that breath, the vacuum is vacuuming, right? So it's pulling that internally versus when your chest is working its way out. And since that's free floating and there's no true structure anymore, that's where you're going to start to see that movement.
Yeah, so for that assessment specific stuff, I really typically going to be visual, and then maybe being able to feel that different section of the chest moving differently than the rest.
Yeah.
Lung sounds maybe will be affected if there's something underlying going on, but not just because of a flail segment. It's not going to change lung sounds or anything.
I think that's one of those, you read the mechanism, right? Because then we got like pulmonary contusions, maybe cardiac contusions, depending on the area, right? So that's where you got to think future implications.
Yeah, or maybe, broken ribs that's going to cause damage internally too.
Right.
You think of that vein, that artery, and that nerve under each rib, right? So if you have a broken rib, that's going to potentially affect those as well. So knowing the anatomy can help you there.
Yeah.
There's a big component of reassessment on this one too, because initially after an injury, I've seen quite a few flail segments that initially after the injury, that epinephrine dump, that fight or flight catecholamine release, especially in a younger, healthier patient with a little bit more muscle mass, those intercostal accessory muscles will spasm and they'll contract enough to the point where they will move that loose rib plate with the actual chest wall.
So it'll look fairly normal.
So again, reassessment in this area, just based off mechanism. Guy took a baseball bat to the side of the ribs, right? We're gonna keep looking at that when they start to get in a decompensated state, or some of that adrenaline wears off from the initial injury. That's when you might start to see these a little bit more pronounced.
See, that's the pro tip stuff of that, because when you're in school, especially medic school, it's like, this is the issue that they're giving you in this scenario. And once you find the issue, it's kind of over, right?
Yeah.
Like you do your treatments, but then in real life, it progresses and progresses and progresses. And we're so used to training in such a snippet of a moment, and we don't get that full effect until you see it and deal with it.
Yeah, and Casey and I had one a few years ago, a flail chest, where it was a interesting scenario because it was this huge car accident, and we basically all went into this accident and got stuck behind the accident and had to call more units to come up the other way to get patients through.
That was a cluster.
That was. And Casey was the one that found, and it was like, he saw it and like snapped, oh, flail segment, that's cool. One of those moments where we all was like, oh, look at that. Because I think it was the first one I'd ever actually seen in the field. And yeah, it was just one of those where, well, there's a flail segment and we are in the middle of a highway right here. We can't even get him to an ambulance yet because you're stuck. And so it was, we had a long time with this patient with the flail segment. Ultimately, I think we just gave the guy oxygen and took him into the hospital. But yeah, I feel like that's that disconnect from the school to the field is right. You see it in school and you're like, oh, there's a flail segment. And then you're like, okay, cool. You found the injury. You're done, right? Well, that's where it starts, right? You need to know what to anticipate, as Casey was kind of talking about, and how to manage that from there for potentially quite a while, depending on the situation. So,
Right.
And that was, if I remember, that was long enough ago that like the change of externally splinting it, although it didn't make a lot of sense, hadn't quite changed to the new method of internally splinting it.
yeah, it hadn't
least
reached
hadn't-
protocols yet.
Right,
Yeah, like
yeah.
we all kind of knew what you should do as
Right.
opposed to what was being practiced in the field, which is, yeah, at that
Right.
point, there was still some like, do you splint it? Do you not? And
Right.
now it's more of an internal CPAP, BiPAP intubation route if needed.
Yeah,
Right? That
yeah.
guy wasn't quite to that point, but yeah.
So let's talk about real quick. Just I think we can kind of differentiate like flail segment on its own, not really a life threatening thing, right? Like going to cause some pain. Maybe there could be some secondary things, but just an isolated flail segment with no vessel involvement or anything. It sucks. It's painful. Maybe there's going to be some, respiratory distress because of the pain and because, the chest wall is not structurally sound, but probably not life threatening, right? So, just I think we can maybe establish those things, right? Just isolated, lower priority.
You can
essentially.
compensate with it for
Yeah.
a long time.
Yeah.
Unless there's other stuff going on.
Yeah,
obviously.
exactly. So treatment wise, you guys kind of already talked about it. So historically, when we all went through EMT and medic school, right, we talked about external splinting. So if you're old enough, like a couple of us here, they probably talked about like sandbags on the chest, which we were joking before we even started this, like, who thought of that? Like, how was that ever something that seemed like a good idea?
Tape like a bag of saline
Yeah.
to it, big bulky
Big
exterior
bulky
dressing.
dressings was kind of what, like something really solid.
That's what they taught back in the day.
I don't And it's one of those things where you think about it, like, as an EMT student, you're like, yes, sir. Yeah, sure. Yes, that makes, I don't understand it, but you're telling me. So yeah, it totally makes perfect sense. I totally get it. And then you start to think about it and you're like, how is that supposed to do anything?
Right.
Like, I don't understand the why of it. Right. But now, internal splinting. So what do you guys mean when you say internal splinting of these? How do we accomplish that? And what are we trying to do in that situation?
Yeah. So again, going back to anatomy, right? The chest is a closed vacuum, right? Just as we're sitting here breathing now, it's based off negative pressure, right? Our drive to breathe is based off a negative pressure that the diaphragm creates going down, and then it goes back up to release air. So to splint internally with this type of injury, we are going to add pressure to that already closed system, right? So we can do that in a couple different ways. We can do CPAP. I don't think BiPAP has hit regular medics yet, has it?
It's starting to.
Is it starting to? Okay.
Bi-level.
Bi-level.
Excuse me. Yeah. Bi-level. Either CPAP, continuous PEEP, or that bi-level, with also, that continuous PEEP. You can do that with intubation, obviously. You can also do it with another pro tip here. If you're ever going to use a BVM, make sure you have a freaking PEEP valve on it, for the love of God. But yeah, we can do that also with a BVM and a PEEP valve, given that you maintain a seal, right? Adding that extra pressure in there is just going to, again, from the inside, put everything on an equal level and make that detached rib plate move with the rest of the chest wall because it's being pushed outwards.
Yeah. So instead of sucking air in, we're pushing air in, which pushes the chest wall out. Right. So we're going positive instead of negative pressure.
Exactly.
Just out of curiosity, would there be a benefit to externally splinting and internally splinting? That way, like, you're not over pushing through depending on the fracture. I'm just spitballing. I don't know.
I mean, yeah, I see where you're going with that. I think it would be, you would have to put a lot of PEEP on board.
Gotcha.
To have that be a concern.
Okay.
And when I say a lot, I'm talking, this is an arbitrary, I would say north of 20, 25 PEEP.
Which that's a lot.
That's
way
a lot.
half.
Yeah. A lot of people ask how much PEEP, right? 5 is never a bad place to start. 10 is quickly becoming the new 5, just kind of in general. So I'd say to start with, anywhere from 5 to 10, you're probably in a safe space.
And because we did a PEEP video a while ago and researching that, I found kind of inconsistent information that physiological PEEP is like 2 to 3 or like 5. I found both. So I don't know, can you guys speak on that or any stuff you've seen in training? Like what?
Mostly that. Yeah, I've heard 3, and then, patients with COPD and asthma might have a little bit different numbers, but yeah, I think in general, like 3.
Yeah, so probably a little higher for the COPD or something.
Like us right now, we're probably all
so.
around 2 to 3. You add a bunch of dead space with a vent, then you need to start adding a little bit more. So I think that's where the 5 comes in.
Okay.
So if you are going to tube somebody, you should probably never start. There's never a reason to start anywhere below 5, just because of all that extra dead space.
Yeah, and that's what I've found in all my research is 5 is kind of the starting point, but I found inconsistencies in what intrinsic PEEP numbers were. So, and that's just medicine, right? It's always going to be the case where you're going to find things as new information comes out and things will start to change. So, cool. Anything else? Flow chest? I think it's a pretty basic one as far as what we're going to talk about. Let's talk about pneumothoraxes. Who wants to kind of talk about pneumos and what those are and treatments and all that?
Sure. I can talk about
mustache side of the table will continue.
Okay. So pneumo, pneumo and hemo in general, it's going to be tough to really differentiate in the field, right? And so what we're going to see, so what a pneumothorax is air in that pleural space that's going to essentially push against the lung tissue, the great vessels, the mediastinum,
How'd you pronounce it?
Mediastinum?
He
What?
says mediastinum, and so
mediastinum.
I was trying to accommodate. I'm sorry.
I've always heard mediastinum, so
I like
The mediastinum.
I like
Mediastinum.
mediastinum better.
That's what at least I whatever.
I just like saying Stein. I don't know why, but
This is not Germany.
Yeah. So
let
really
me have
what
my EKG. Okay, let me talk about my EKGs.
Okay. Yeah. So a pneumothorax, air in the pleural space from generally some sort of external force, right? Whether that be, penetrating trauma. I think I've read a stat. It was something like 85% of penetrating trauma leads to a pneumothorax. It doesn't mean it's going to lead to something we have to do something about it, but it's a very high number that will lead to a pneumothorax. So air in that pleural space. And so what a pneumothorax can progress to is a tension pneumothorax, which is where the mediastinum gets shifted over. Those great vessels get
I got it.
moved, and it can cause decrease in our cardiac output, right? And so that's where it becomes a life threat. And really, this has been a big push lately because I think for a while people are getting a little bit too ahead of themselves with treating pneumothoraces with needle decompression, where we don't treat it until it's a tension now, right? So when we have that decreased cardiac output, that's when it becomes a tension pneumothorax. And so a hemothorax is essentially, it's blood in the pleural space. Hemo, blood, pneumo, air, right? So hemothorax, blood in the pleural space. You think about all those veins, arteries, nerves underneath the ribs, all those great vessels. If any of that gets affected, you can dump blood into that pleural space, and it has kind of the same effect as air. It's going to start pushing on the mediastinum.
Closed vacuum.
That closed vacuum, yeah. And you can also have a hemopneumo, which is, you have air and blood in the pleural space, so both of those pushing in on that closed vacuum system. So
Can I throw one more pathology in there?
sure.
So you can have a chylothorax as well,
Is that
or a chylohemopneumothorax. So this is lymph fluid.
Oh, yeah, okay.
So a lot of lymph vessels running through the chest. Any new introduction of air, blood, plus this 1 to 2 liters that we have circulating of lymph fluid in our body can also kind of tip you over that edge into tension as well.
Never heard that
If
before.
I'm going to walk in, I think, Doc, he's got a hemopneumo. I want that someday.
Yeah.
So
Doesn't change treatment though.
right, yeah. So yeah, in general, the way those are going to present, right? So we probably aren't honestly going to detect a very small pneumothorax, right, or a small hemothorax. They're going to maybe have some chest pain. They're going to, may have pinpoint chest pain. We're going to look at that mechanism of injury, right? Did they get something that could cause a rib fracture, blunt trauma, or is it some sort of penetrating trauma? If it's penetrating trauma, you can assume they have something going on, right? That blunt trauma is where we're going to have to do a little bit more diagnostic kind of an assessment. As a pneumothorax or a hemothorax progresses, it's going to cause, think of your signs of shock, right? Some tachycardia, some tachypnea. They're going to have chest pain, right? Or, chest wall pain. So they're going to start breathing potentially a little bit shallower because of that pain, a little bit more rapid, that tachycardia. And then as it progresses more, you may have those decreased lung sounds, right? That's going to be quite a ways down the road, but decreased lung sounds, blood pressure changes are when it's kind of getting into that tension physiology. So when you start getting blood pressure changes, tachycardia, decreased lung sounds, that's like your classic. That's when you need to, that's kind of where my threshold is of we need to treat it now, right? So blood pressure changes, SpO2 potentially going to be a lot lower as well. And then at that point, it's going to be, you're going to get those late signs of the tracheal deviation and the JVD, which is, if you see that, they're probably peri-arrest, right? Mm-hmm. Or if they have already arrested. So, it really progresses for the most part for treatment. Do you want me to talk about treatments a little bit?
Yeah, let's talk about treatments.
Sure. For the most part, throw them on oxygen. Most pneumothoraces are going to fix themselves, like 80-something% fix themselves. So high flow oxygen is that treatment, non-rebreather, right? So throw them on high flow oxygen, even if they may not need it, right? Or they, their SpO2 is great. That's what ultimately treats a pneumothorax in the vast majority of settings.
Their SpO2 is great now.
Exactly, right. Mm-hmm. Yes. Same with hemothorax. We're not really going to know the difference in the field, right? So just treat kind of both the same. High flow oxygen, continuous reassessment, continuous vital signs checking, looking for all those signs that I was talking about. And ultimately, if you do deem that there is a tension physiology, we need to treat with needle decompression. Really needle decompression. And then you can progress to finger thoracostomy in certain settings. Usually it's reserved if they go into cardiac or trauma arrest. They're kind of getting the difference between medical and trauma now. Trauma arrest, that's where we kind of start going into like the finger thoracostomies as opposed to needle decompression. So needle decompression for your tension physiology before you do any positive pressure ventilation, right? So if you're introducing positive pressure ventilation into that system of tension physiology, you're going to code that patient quick.
100%, yeah.
So you need to recognize that tension physiology and treat it over and over potentially, because that needle can potentially get occluded. And so we need to reassess to make sure that's not happening. And so I don't know if you want to maybe walk through a needle decompression.
Real quick, one thing I want to add too is if there's a hole, we got to cover the hole with an
Yes.
occlusive dressing,
Yes.
right? So,
Yeah.
and we talked about it earlier, but that air is being introduced somewhere into the space if they are continually getting worse and going to attention physiology. And so that air is happening because that negative pressure, it's normally we have, one pathway for the air to get into our chest when our vacuum is created. But if there's a big opening in my chest here, now there's another avenue for air to enter into my chest cavity. And so we need to plug that to stop that air exchange going back and forth.
You do that even with the finger thoracostomy. After you make a hole, you make it a one-way cover, right? You still have to cover that hole so air doesn't get in. Air can hopefully get out, but you still have to cover the new hole that you made.
Yeah.
Can you expand on finger thoracostomy? That's a newer thing.
Yeah, so finger thoracostomy is kind of rapidly gaining some popularity and some trendiness, if you will. I'm sure most of us have kind of experienced the needle decompression can fail. Like it's kind of the way I look at it is it's like an LMA or a King airway versus a tube, right? The angiocath might not be long enough to get into that pleural space. It's really hard to tell sometimes if you are in that space, if you don't hear this big rush of air, which you don't always get, or geyser of blood, if you will. And the term finger thoracostomy is kind of misleading. This is still a instrument-driven procedure.
You're not just jamming your finger.
You ultimately do.
But I mean, like after
the
your
very
instruments will do something.
Yes.
Yeah.
After you've popped through that pleura, right? These are the first 6 steps in putting a chest tube in.
Yeah.
I don't believe a sterile field exists in the field, so you're going to try and make it as clean as possible. Up to and including betadine. You're gonna, if you have time, you might even anesthetize a little bit with Lido. All the things, dependent on the situation. But you take a scalpel, similar positioning to a chest tube, fourth intercostal space, anterior mid-axillary line. You take a scalpel, and then you blunt dissect with a pair of big hemostats, big Kelly clamps, essentially, and you pop that through the pleura. Same thing, you're going to go over the rib. And then when you're through, right, you'll blunt dissect a little bit, and then you'll put your finger in, kind of sweep around cautiously, right? Rib fragments can cut you or poke you. But yeah, put your finger in. I assume that's where the term finger thoracostomy came in, because the last step is to put your finger in. But this is an instrument-driven procedure. It does take a little bit longer, but it is, again, it's that definitive, I know I am in the pleural space. I know I'm in that chest wall. There's kind of a new interesting toy out there with needle decompressions. It's called capnostat.
I saw that the other day.
So think of our colorimetric things that we used to use. We'd put them on tubes, and it would go from purple to gold when it detected that CO2. Very similar.
Interesting.
You put it on the end of a needle, poke into the pleural space. If that turns yellow, if it detects CO2, then you are in the pleural space.
That's neat.
It seems really simple, but it seems really smart.
Yeah.
Unless it's a hemo, I guess.
Unless it's a hemo. I mean, and you would still get CO. There would still be,
true.
CO2 in that space. But one of the reasons why we're kind of trending towards the more definitive finger thoracostomy, or simple thoracostomy is what it's also called, is collectively as medical providers, I'm talking doctors, nurses, medics, NPs, PAs, everybody, we collectively suck at hitting the right landmarks for a needle decompression.
Yeah, there's graphs out there, and it's real
awful.
bad.
We're terrible at it.
So needle decompression, right? The proper way to find those landmarks. So there's 2 sites, and in general, the preferred one is the anterior axillary 4th or 5th intercostal space, because of the potential for things to go wrong in that 2nd intercostal space. And so what you're going to find is you could look at your clavicle, and I think what the problem is, a lot of people think their clavicle ends at their shoulder, or the inside of their shoulder joint. It ends all the way out here. So you're trying to find from the beginning of your clavicle all the way out to where it ends and find the actual middle of that. So a lot of people go way too medial. And so that's kind of the problem people tend to run into, is going way too medial. And another way you can find your landmark is you can use a patient's hand, put it under their armpit, and essentially 1 hand width, so 4 finger widths, is going to give you a pretty close site to that 4th or 5th intercostal space. You find, they have your mid-axillary line, your anterior axillary line. You're going right kind of in between those, and that's it's blanking on me what it's actually called. There's another axillary line.
The anterior axillary?
Is it just the anterior? Okay, yeah. So I had it right. But so that's what you're going to find, and that's where you're going to put that needle in. In general, you're going to want to put that needle in over the top of so you have that intercostal space with the 2 ribs. That space, you want to go over the top of that bottom rib, not under that top rib, because of those veins, arteries, and nerves. So over the top of that bottom rib, you can actually, I always go in at a little bit of an angle. You feel it kind of slide over that rib, and then you go in. So that's kind of the way that I find the landmarks on a needle decompression. And that's how I always taught my trainees as well. And
it's the same thing with that blunt dissection instrument with a finger thoracostomy or a tube.
So finger thoracostomies, it's just to relieve the pressure. We're not attaching a vacuum or anything to it afterwards. No. Just to relieve that pressure.
In the terms of a simple thoracostomy, yes, you're making a new hole to relieve the pressure. Now, like we said before, we do want to cover that with a chest seal. Hopefully, it's got a valve on it. Even if it doesn't, you could slap a defib pad on there, the same thing, and burp it as needed. Right? It's not as likely to get clogged like a needle would. So if you need to actually burp it because they're rebuilding that pressure back up, it's just pull it off a little bit, burp it, stick it right back on.
Yeah, and that's one thing about occlusive dressings that I always loved is whatever works, right? Like, I know we worked with somebody that worked in an area with a lot of 22 gauge gang shootings, and she would put EKG leads.
Yeah, electrodes.
Little electrodes on there. Like anything that will fully seal. I always tell classes dude, if you got some potato chips, the bag, cut that up and tape it on, and as long as it's non-permeable and air can't pass through it, it's going to work, whatever it is. So
the petroleum gauze was an interesting one I'd never seen before.
Yeah, that was kind of, I don't know about you, that was like the standard that I was taught back in EMT school. Petroleum gauze was kind of what we were all taught, which it works the same. I think people like it because it just sticks on the skin really well. Yeah. It's hard to pull off.
And back then, there was all these little tricks. You could take the packaging of
your petroleum gauze
and of the petroleum gauze.
Probably works better than the gauze.
Right, or the Curlex or whatever plastic packaging, and you could tape it on 3 sides. And, that was kind of military medicine back in the day. It is. I will say it's hard to, especially in a bloody environment, it's hard to tape anything down.
Yes.
Right. So, and that's kind of where I stopped trying to do some of those other techniques. And if I didn't have a SAM or a hyphen, like actual chest seal, I always got a defib pad.
Defib pads. Yeah, same thing. I've learned that commercial device doesn't work well, that defib pad's going to work for the most part, because if you try it with anything else, just taping it on is simply, if they're bleeding out and you can't stop it like that, it is not going to probably work very well for you.
I have also just used a firefighter. I had a gunshot wound to the chest, and it was like super bloody, and just like, you're just going to put your hand, put some pressure
100%.
over that. And then it was getting bad enough. Like, it was actually one of the grosser things I've seen. When we got to the hospital, it was like, okay, let's change this out real quick. So we had it ready. And when he pulled his hand off, the guy took a breath, and just a chunk of fat and went like, shoop, and just like shot out of the hole in his chest.
Yeah.
And then slapped another one on. But yeah, whatever resources you have, utilize those.
Yeah, use your entire toolbox. I want to put a quick little disclaimer on that. Anything neck to navel, we should be putting.
Yes.
Any holes neck to navel.
Yeah, we should have put that in there earlier.
Front and back.
Front and back.
Yeah, and sides.
Always look for exits.
All the way around.
Yeah, anything neck to navel, circumferentially all the way around your thorax needs to be covered with an occlusive vest.
It's super important. Yeah, we should have said that earlier when I'm talking about. I should have said it earlier, but yeah.
So, because we talked a lot earlier about knowing the why, not just the what, and we're kind of just talking about the what with some of the stuff here. So, Casey, earlier you said I think Casey said, we want to make sure that we've managed that tension before we start that positive pressure ventilation. So, when you guys explain the why of that, like what is happening physiologically in that tension that we don't want to increase the pressure within the chest cavity?
Go for it, mustache.
So essentially when you change from your negative pressure ventilation to positive pressure ventilation, you're introducing more pressure to that thoracic cavity. So your intrathoracic pressure is going to increase. And when our intrathoracic pressure increases, we can decrease venous return to the heart. And so when we decrease venous return to the heart, we can decrease our cardiac output a little bit. That's simply on a patient that doesn't have a lung injury or anything else. And so what happens when we have a tension pneumothorax? We have increased intrathoracic pressure and decreased cardiac output. And so if we combine those two things, adding that intrathoracic pressure on top of that tension physiology will dump our patient's cardiac output, because those great vessels are essentially going to occlude themselves, and that patient will no longer have blood flow to their heart and no longer have cardiac output. And so it can be very quick.
Yeah, it's important to remember that tension, all that, the chest cavity is a finite space. It only has so much space, and it's supposed to be filled with lungs and heart and great vessels and all that stuff we talked about. And if a third of that space is now being filled with air or blood, it is physically pushing on all those important structures. And so we don't want to further increase that pressure within the system, pushing on those structures and strangling out the vena cava and dropping that blood return, or making the heart not be able to expand as much, because it doesn't just push, it fills, right? And if there's a lot of pressure on it, it can't fill enough and so it won't push blood out, right? So that's why we want to manage that tension before we really start to be aggressive with positive pressure ventilation.
And
our heart literally shifts in our mediastinum, and it just, that whole thing just shifts over and occludes those vessels. Sorry, it's just, I had to.
That's good. I usually describe it like to the students when I describe tensions. It's like, imagine your great vessels are just being kinked like a hose, and then your heart's getting squeezed on. So if your heart's being squeezed on, it can't fully expand. If it can't fully expand, it can't fully fill, and that's where your cardiac output starts to drop.
And not to beat a dead horse, but going back to assessment, this is where it's so important, because as we discussed with a flail segment, positive pressure is now the go-to treatment.
Yeah.
But I would say, depending on mechanism,
Be careful.
there's a solid chance that they have either a hemo or whatever kind of pneumothorax going on as well. So if we just get fixated on that flail chest and we start dumping a bunch of PEEP on them, that's gonna drastically reduce their time to meet Jesus. You know what I mean? So yeah, that just going back, that initial assessment and that continual reassessment, it's so important. You can't overstate it.
Yeah, and Mike touched on it a little earlier too, of like, not every pneumo needs a treatment, but when you need the treatment, you better be ready to give it. That's where, once again, that full assessment is so much more important than people give credit to.
Yeah.
And I've almost gotten to the point where I'm so thankful if I have a pneumothorax patient who's already intubated. Because again, in the kind of environments that we practice in, detecting the early signs is really difficult. So if you already have them intubated, and this is potentially a reason to pull the trigger on intubation if they're not already, but being able to monitor their peak airway pressures and their PIPs and stuff, that is a really good, easy way to kind of catch it before they get into those late hypotension, tracheal deviation signs.
Will you see an increase in that PIP, those peak airway pressures, as they start to tension?
Exactly.
Essentially?
Definitely. Yeah.
Along with, like Mike said, they're probably going to get tachycardic a little bit. If they're not already intubated or sedated, they'll get anxious. They'll probably start breathing fast. All those things. But again, I like the intubated patient because those peak airway pressures and those PIPs are relatively black and white. Like I see this kind of trending slowly upwards. I need to figure out why. You know what I mean? And I need to fix it.
Yeah, and I'd imagine, because when you guys are in the rotor, I'd imagine probably even like the fixed wing, like lung sounds, you probably can't really do lung sounds, right?
It's
so
not a thing.
you have to have those other things you're looking at, right?
Right.
Like peak airway pressures and looking at do the puzzle pieces of the mechanism and these things fit together to make me think I'm seeing right.
That whole look, listen, and feel thing, I had to like relearn it when I got into flight because we were working under a rotor disc for most of our patient contact, and you literally you can barely talk to the patient, right? You kind of sign to each other a little bit, but it's very important to have like a physical assessment done and redone in that environment. Yeah.
And something that you can quantify definitely makes sense too. If you can't use your hands-on stuff that you've used your whole career, that makes a lot of sense.
So let's move on to the next thing, which we have to talk about is going to be some cardiac tamponade. So who wants to kind of explain, and in the context of pneumothorax, it's kind of simple, but anybody want to explain cardiac tamponade?
I can talk about it. So with cardiac tamponade, essentially we have some sort of chest trauma, right, that has now irritated the heart, and we either have fluid shifting or we have blood filling up, but essentially it's that pericardial sac around the heart, and it on the same kind of breath as a tension, where now that sac is filling and starting to put pressure down on the heart. And once again, if the heart can't fully expand, it can't fully contract, so it can't fully fill. So you're going to start seeing a decrease in cardiac output, and then circulation is going to start diminishing, and blood will stop going round and round, essentially.
Frank Starling, right?
Yeah.
Yeah.
Exactly.
Yeah, you want to explain? That was one thing.
Yeah, you said it. You can explain it.
Yeah, that really clicked for me. Like, really, I still remember like studying, and I didn't understand. I think it was more in relation to cardiac output and preload and afterload, and it just wasn't clicking. And then I read something about Stirling's law, and it was like, oh, that makes sense. You want to explain Stirling's law?
Yeah. So Stirling's law, and this doesn't necessarily just talk to traumatic pericardial tamponade.
No, not at all. Yeah.
This is just kind of we'll call it physics of the heart in general. But think of a rubber band where the further you stretch it, the harder it's going to snap back, right? And you can take that too far, where you can stretch the rubber band and its elasticity is gone, and it no longer contracts. So you have to have a good balance of being able to expand and then rebound back to give you the most output, right? If you start filling up blood and putting pressure on that heart in the pericardial sac, it can no longer expand. Therefore, it can no longer rebound as much to push blood out.
So preload is that stretch on the heart. And that's for me was kind of hard to think about. And that to me, that's how I remembered it, right? Like preload is that stretch on the heart, right? It's that peak point, the amount of pressure before there's a contraction. And so as we drop preload, we have less stretch, which means less rebound contraction, which means less output.
Right.
Right. And so that's really important for us to remember in the context of this, because if there's, again, the pericardial sac's a finite space, and the heart should be able to expand and contract within it. And if there's half of that's taken up by blood, there's only half the space for the heart to expand. And so it's only filling up halfway. And when it contracts, we're only having half the blood ejected that we should. Right. And those numbers are not real numbers, but just kind of like, a visualization, if you will.
Conceptual.
Conceptual. Yeah. So,
Yeah, and that's where you go back to like the school of Beck's triad, right?
Yeah. So how are we gonna recognize cardiac tamponade?
Yeah. So we talk about the heart. So it can't contract as well and it can't fill as well, right? And so what's going to happen is it's going to lower your systolic blood pressure because it can't eject enough pressure out, but it's being squeezed on, so it's not able to fully empty either. And so both numbers end up rising, the systolic falls, the diastolic rises, you get a narrowed pulse pressure, which is the difference between the two. And then you can talk about muffled heart tones and JVD. And, I didn't listen to heart tones until I started flying and working with nurses because they made me start listening to heart tones.
But again, given the environment that we do it in,
you can't do it in the road. You have to do it in
that can be really hard to detect muffled heart tones. It's
I'm
hard
not
to
good
detect
at it.
regular heart tones sometimes.
Well, yeah, and that's we teach Beck's triad with muffled heart tones, but does anybody actually put in practice? Not really. And for you to be able to be like, that's a muffled heart tone, you better know really well what a normal heart tone is. So
yes.
it's there, and especially if you're a student listening to this, you need to know that for test questions. But in practice and what we do, and especially, in the ER, I'm sure doctors listen to heart tones all the time because it's nice and quiet. And the ER is not always quiet, but compared to the side of a freeway, right? Like you can actually listen for those things. But I probably said this 100 times on this podcast. You will never recognize abnormal until you know what normal is.
Right.
Definitely.
And so this is one of our failings. We just don't listen to heart tones enough.
Yeah.
And then, the JVD makes sense because blood cannot get into the heart. And so it's going to back up. It's a traffic jam, right? So it's going to back up somewhere. Yeah. So both of these things can cause shock. And these are pretty definitive for obstructive shock, right? These are two big obstructive shocks that we're going to find.
Yep.
And I think with chest trauma in general, that's kind of the big, that's your big, it's a hypovolemic shock and obstructive shock. That's what you're going to really, the rest of it's kind of, oh yeah, we see this. There's not a lot to do about it, but that obstructive shock and hemorrhagic hypovolemic shock is really what we need to recognize and treat right away. The rest of it's just kind of style points.
Yeah. Treatment for this. Do you guys? Because I know when I was coming up, like it had been moved out. There's not really anything the ground medics could do. Flight medics still could. Can you guys still do the pericardial centesis, or is that kind of out of the scope?
I think if I did it, I don't think I'd have a job very long if I did one in the field without like very much direct guidance. So in general, I think it's very dependent on where you work and very dependent on your protocols. I think it's still technically maybe in the scope of like critical care, which flight paramedics are, but that's a big but of where it depends on where you work and your specific agency.
So why is that? Just curious. Is it just?
I think it's such a high risk thing that gets screwed up. It's the lowest common denominator, right? Someone screws it up enough, they're going to take it away. So I think
I was thinking
screwed
infection
up.
relation too, because we're never sterile, and so you're putting it straight into that pericardial.
And even when I think ground paramedics could do it, from my understanding, it was essentially a last ditch cardiac arrest thing, anyways.
That's exactly what I was just going to say. So at my agency, that's exactly what it is now. We have permission to do that as kind of a last ditch resort with a little bit of a mindset. Well, at this point, they can't get any deader.
Yeah, they're already dead.
You know what I mean? Which I've never been a huge fan of that saying, but it's not necessarily untrue. I will say that there's, with all of these new studies with blood and all of these potential preventative things that we could be doing out in the field, there seems to be a little bit of a paradigm shift, and medicine's slow, right? It's going to take years and years, maybe even a decade for something new to kind of hit the streets as a regular practice. First, it's got to be done by the military, then it's got to be studied by whatever college and whatever group and whatever certified board of physicians. But there seems to be a little bit of a shift where even working a traumatic arrest, things like CPR, it's not ruled out, but it's deprioritized until you fix the air in and out and blood round and round type deal. So it really wouldn't surprise me to see something like pericardial centesis kind of start to make its way back into regular practice. Because again, that, at least on paper, that is an injury that could be treated in the field, has been treated in the field, that could prevent death. that is one of those things where you might not be able to wait till you get to the surgeon. We need to take care of this now.
Yeah, and you bring up a good point with like the traumatic arrest, right? So and this is kind of the policies I've worked on. And I know a lot of ground agencies are even going to this now, where if it's a traumatic arrest, especially if there's any inkling of chest trauma, we are not worried about CPR. We are worried about fixing the underlying problems: bilateral finger thoracostomies, intubation, and then proceeding with CPR, because at that point, really, it's not a heart problem. It's a hypovolemia or obstructive problem. So if you can fix that physiology, their heart's probably still beating electrically, right? And so it's just a matter of getting it to fill back up because of that tension physiology or that hypovolemia. So, traumatic arrest with chest injuries, generally you go in and the first thing you do is you do your, stop any bleeding that's still happening potentially. But then it's, either your needle decompression or your finger thoracostomies, depending on where you work. It's placing an advanced airway and then starting on things like CPR. Medications are essentially thrown to the wayside. Maybe some epi, maybe a little bit of epi, but other than that, it's blood if you have it. After that,
Blood products, yeah.
Blood products.
So with the introduction of because you guys being in flight, you're going to get the cool toys probably first. With mobile ultrasound, could you see pericardial centesis? Would that assist?
I have this could go down a rabbit hole. I'm not a huge fan of the ultrasound thing, and I think it has its place, but I think people that don't know how to use it fully place way too much emphasis on ultrasound and use it as instead of a good assessment, they're just going to use ultrasound.
Like a crutch almost.
And then they just use it as I think it has its place, but I think it's too high priority in a lot of settings.
There's a finite number of things that I can think of where it would be advantageous for us and for patient care and for patient outcomes, and a much larger group of things that I think will end up ultimately hurting us and patient. So
sitting on the side of the road waiting to ultrasound the belly when they should be
going
at the hospital, ultrasounding the belly at the hospital, because they're going to do the same thing when you get there, right? So
tube placement is one thing I can think of. Although it's been doing it for almost 20 years, there's other ways to tell that your tube is in the right place, right? Some of these traumatic things, where you kind of get into the weird dynamic of stay and play, load and go type deal, it can be definitely helpful in that regard. Things like IVs, things like fast exams on a belly that you quite literally can't do anything about. There just seems to be a lot of things that could hinder us that outweigh the things that could help us with ultrasound.
Yeah, good assessment, rapid transport, the basic. I mean, there's not a whole lot of treatments that, other than what we talked about, where we kind of touched on blood. You can go with TXA as well within, I think the time limit is now 2 hours instead of 4, or 3 instead of 4. It keeps changing. So yeah, TXA, blood, those treatments we talked about, the finger thoracostomies, needle decompression, airway management, go, right? And do it all en route if you can, right? So don't forget that this patient needs to get to the hospital ultimately. We are not surgeons. As cool as we think we are not that cool. So,
but do surgeons fly around in a helicopter?
Some do.
They're the really cool.
Yeah, they're the whoa, yeah.
So the answer is no.
Yeah.
To my question. Okay, cool.
So one thing we probably should have talked about a minute ago too, pericardial centesis essentially is where we take a very long needle attached to a syringe, and we're going to go under the sternum at an angle towards the heart. And the way because we learned it in medic school, or at least we learned in theory, we didn't learn in practice, but you're going to go incrementally, a couple centimeters, and you're going to pull back and see if you get blood. And then you're going to keep going. Hopefully you will get to the pericardium, you'll pop through it, get into the sac, and be able to suction the blood out of the pericardial sac to allow the room for the heart to be there again. I just realized maybe people listening to this are like, they're saying this word a lot, and I don't know what that is.
No, that's a good point.
So that is the treatment that we're talking about in regards to cardiac tamponade. But yeah, I can think of one person I know maybe who's been a medic longer than you have, who's done it before, but it's just not a super common thing.
Yeah, I've never done it. And I would imagine it's similar. One of the reasons they took it out, if we collectively as a group suck at hitting needle decompression marks, I mean, you can imagine with something we do even less, it would be hard to, get the experience to be good at it.
Yeah, it's like central lines too, kind of similar.
Yeah, 100%.
Which, that's probably going to make some old school medic really mad that we just brought that up. But.
Dexter, if you're listening. I'm sorry.
And anecdotally, from what I've been told by the really old school guys, a lot of the time when they would see these things, then they would suspect cardiac tamponade. A lot of the time it was front end auto accidents prior to airbags. That was like the really number one time they would see this, especially older cars that maybe just had lap belts, not shoulder belts, and especially older folks that were, old blue haired grandma driving 6 inches away, with her 6 inch away, your blue haired grandma, from the steering wheel, and that front end crash, they would go chest into the steering wheel, and that would cause that blunt trauma, where that's just now with vehicle safety measures, we just don't have that as much. So, I've always heard anecdotally that's maybe a part of it too, that we just don't see cardiac tamponade very often. Yeah. And so high risk.
It's usually
low
any shear
frequency.
force. Usually you have some ligamentum arteriosum detachment in our shear as well. So another kind of cool finding, it's a relatively late finding, but on the EKG, you can start getting electrical alternins. So think of that heart beating inside a fluid-filled sac. It's going to pendulum, especially if you have that ligament shear. It's going to pendulum a little bit. So you're going to get different shaped morphologies from complex to complex.
See, now every patient you have now with the alternons, you're like, oh. Pull that needle out.
Yeah.
Also, I'm not surprised that Casey comes in with some heavy
Some
EKG knowledge on something like chest trauma.
And I mean, to the
Notice how that was the first time EKGs were brought up in this whole podcast, though. Like, it doesn't mean you just have to slap on the forelead when you show up, right? Yeah, like
I think for any student listening, that's such a valid point, right? Kind of making a joke of it, but I have seen it as an FTO of like, especially I feel like people that came from working in the hospital as like techs, are like they're just that EMT brain of like everyone's gonna get this. And I had one rollover accident, like a patient had like no sensation in a leg, we were waiting for the helicopter to land. We were flying this patient out, and another medic, we're going to load into the gurney while we're waiting, or load back of the ambulance to get him in a controlled environment while we're waiting for the bird. And other crew was there, and the medic is standing at the back with the forelead in his hand. And I was like, what are you doing? We need an IV. Like, I don't care about it. What, his heart's fine. Like, you know what I mean? And a good point. Like, we never talked about it because it's not important in this situation.
You got to know the important stuff first, and then you can start,
Then you can start.
I think that's something that's really important, especially for like the paramedic students.
Stuff.
Exactly. Yeah. The paramedic students listening out there, it's not, they walk into a scene. I think everybody wants to just, let's get the forelead, let's get a full set of vials, let's get a blood sugar, let's get a temp, let's do all this stuff. That's not really thinking through what's happening. So think through what's happening, get done on what needs to get done right away, and then move the scene along.
It's all about those whys, like we were talking about.
Yeah.
It's almost like a game too. Like, you're going to get different style points for different call types,
right?
And like end of the day, we dealt with it. We've got an IV, everything's ready. Let's put a forelead on. What's going to hurt, right? Like style points.
Yeah.
Not really going to change anything.
It's more for documentation than it is for actual patient treatment.
Yeah, or if you're going to maybe be giving other treatments that maybe you'd want the forelead on for. Right. Real quick, let's keep going because we're going later on time than we thought. So another one to talk about is going to be commotio cordis. And so that is a direct blow to the chest at the correct time in the EK or in the cardiac cycle is going to cause a patient typically go in like a ventricular rhythm. For this, I think there's not a lot assessment wise other than like knowing the mechanism was blunt force trauma to the chest, and now they're unconscious and coded, and we need to kind of move on from there. So
especially your younger patients,
younger in sports. This is a sports injury, very
Little League classic example.
I love how we bring this up right after your cardiac rhythm should be secondary.
There we go.
But at very minimum, it's never a bad idea. I mean, I know a shockable rhythm inside of a traumatic arrest, the odds are astronomically low.
Yeah.
But putting pads on, and if you have the ability to read a rhythm off your pads,
It's different.
that's a little different. It's a little bit easier. It's a little bit faster to do. And it does kind of cover your bases for if that low odds shockable rhythm were to happen, such as commotio cordis.
And yeah, I think if they're in cardiac arrest, I'm still putting the 4-lead
For
and the pads
sure.
on, right? If when I show up.
At
doesn't
minimum
change.
pads.
Yeah,
And
we're talking more of like your general trauma. The first thing you shouldn't be doing is just like walk up and throw your 4-lead on, 3-lead, whatever.
And even still, like if you
Really?
walk up, you walk up to a trauma patient, right, and they're unconscious, and I'm gonna do my look, listen, feel, and all of that. My partner's right here. I might have a fire crew here. Like, hey, they're unconscious. Put the pads on because I'm probably gonna need them if they're unconscious.
Right.
I'm gonna start to do my look, listen, feel, and I'm not finding any obvious things to the chest, right? So we can do multiple things at a time.
Yeah, definitely.
So
It's all
it is-
resource dependent.
It is funny that we were like, we didn't even say EKG, and like, well, you better check your EKG. But yeah,
Eventually.
this is what it comes down to, knowing the story really well, right? Like we were talking about Little League kids, or there was I know
Damar
you know,
Hamlin.
yeah,
Damar
the
Hamlin,
NFL
yeah.
story, direct blow to the chest, and otherwise healthy individual goes into cardiac arrest for that with no other obvious signs. Then we kind of need to be thinking this.
Yeah, that video is incredible too.
It was,
If you've ever
yeah.
seen it, like it's as textbook commotio cordis as you can get. Yeah,
you-
interesting.
For you EKG nerds out there, you medics, more advanced practice people, this is essentially the traumatic version of R on T.
Yeah.
That just kind of sends you right into a ventricular rhythm.
And is it the absolute refractory period, or when does it hit? Do you know?
I believe is absolute.
Is it
right.
absolute?
Yeah, that's
Okay.
my understanding.
But yeah, not a lot for us to do for this, like we talked about, but these are typically managed really well with early defib because nothing else is wrong, right? Like if we think about cardiac arrest, typically it's because there was something that led to cardiac arrest, which is why anytime you read like a news article and like they died of cardiac arrest, I kind of hate that. Something caused that cardiac arrest. Something
Like
caused
saying
the heart to stop.
hypersensitivity for a drug content.
Yeah.
It's just a blanket term. So where this situation, like nothing else led to it, right? There's nothing else to fix. It just happened to push them into a weird rhythm. It's a strictly cardiac thing. If we fix the heart, we hopefully will fix the patient. So, be aggressive with that and be ready for that if that situation arises.
Yeah.
If you're going to precordial thump, do it strategically and do it when nobody's watching. But by all means, do it.
Yeah,
It's fun.
I had maybe 2 patients that went into VTAC in front of me, and I never had the wherewithal
Yeah.
to be like pericardial thump. Like it was
I think it
so
was
low in my priority list.
more of like swear first because they just went into cardiac arrest in front of you and then move on to something else.
Yeah.
They're like, I should have done
I
this.
saw one of our old medical directors do it once.
Really?
And it probably wasn't this exaggerated, but at the time, I swear it looked like he got a running start. A Superman punch.
Like WWF,
Yeah,
like elbow on
a
him.
therapeutic elbow.
elbow.
Like I said, it probably wasn't that exaggerated, but in the time, I was so ramped up, and it was back when I was a tech and an EMT before I ever got my medic, and it was fun. It was cool. It worked too.
Yeah, I don't think much more to talk about commotio cordis. Check out that video, Damar Hamlin. You said
Damar
right?
Hamlin.
It's an interesting video and a good visualization if you've never seen this before.
Yep.
I feel like there's a couple other ones that are lower priority. I think last thing
Kind of touched on a lot of them.
we should really talk about is going to be great vessel injury. Especially, I know we really wanted to talk about fluid replacement and blood products and all that stuff. And like I said, we're running kind of short. So
Blood stuff can be its own.
Yeah,
for sure it
there's
could be
lots
its own
of
There's a
thing.
lot
there.
to that topic.
So great vessels, we have 2 very large. And if you've never actually seen the size of our great vessels, like garden hoses or bigger, right? Like that's not an exaggeration. I'm sure you could find like dissection videos or something like that. But if you're listening to this, you've never seen it, you should really try to see the size because it's profound how large they are. And if they're torn, think of a garden hose and how like the output of fluid from a garden hose, like we're doing kind of the same thing from our heart. So this can happen very quickly. But how are we going to assess? What are our assessment findings going to be for great vessel?
Are they dead?
Likely not a living person. Yeah.
Yeah. Hypovolemia. So you're tachycardia, low blood pressure, poor skin signs, obvious chest trauma. Maybe they have normal lung sounds, right? So you're thinking more like medial, like trauma right into the middle of the chest potentially. Steering wheels, for sure. Airbags could do it. Even your seat belt, right? So you kind of look at the mechanism overall. It's kind of just you're not seeing the other signs, right? And so they're bleeding out obviously, and so you can probably kind of assume. And great vessels, if they bleed, this is not good, right? Like they probably are dead at this
minutes
point.
probably. From when it
If
starts.
that.
Yeah.
And so there's not a whole lot to do. It's rapid transport. It's
I would say a
oxygen.
big part of it's time. You got to be there. It's
Oh,
got
yeah.
to happen like in front of you.
True.
You know, I had a personal experience with this of sorts when I was a kid. A close family friend of ours was big into motocross, and he came up short on a triple and caught his back tire, and he ended up kind of rolling on his chest and just ripped his aorta off his heart. The autopsy, they estimated about 60 seconds before he bled to death. So it's one of those of like,
Even if you're there, you know. Like,
what are you going to do?
And there's kind of two separate phases of this kind of injury, right? If you catch this kind of injury before it's ruptured, right? Maybe you have a minor shear or maybe you have a dissection. It's really all about, reducing stimulus, managing blood pressure, right? Keeping that injury from getting worse. Once it's ruptured, I mean, realistically, unless it happens on the operating table, that person might not have been meant to live.
Yeah.
I mean, it sounds harsh, but
they need blood.
they need blood and they need
lot of
repair, right? Because even if you give blood, but it's still leaking out of this garden hose, you're just filling their chest wall with blood.
You're almost like causing a tension hemo.
You're
thorax,
causing,
essentially.
if you don't have repair, it doesn't matter how much blood you give, you're creating a brand new hemopneumotension.
Yeah.
Yep.
So yeah, if you get these patients before it actually ruptures, another good assessment tool is bilateral blood pressures, paradoxical pulses. So left side?
Right side will be absent, left side will be normal.
Right. Or reduced.
Yeah.
Same with pressure. Right side will be lower, left will be higher. Right. If you have the wherewithal to do bilateral pressures or feel pulses, great assessment tool. But if it has not ruptured yet, timely transport, but as gentle and as calm and as blood pressure lowering as possible.
As
Sing to
in
them.
that situation,
And
try not to
recognize-
let the fear be on your face for the patient to
Right.
recognize in that situation.
Duck on the pond.
And really, it's like you're not probably going to know it's a great vessel, right? Unless they're coming from a small hospital and you're taking them to a major center, right? If you show up on a scene like this, you can suspect it, but this is a really tough one to.
It needs to be a differential, but not a diagnosis.
Yeah, exactly.
Yeah.
Yep. And then just in general with your if they're bleeding out, it's if you have blood, give it. There's a lot of science behind, we've been overloading patients with saline for years. It does a lot of damage. We don't want to be doing that. And it's almost worse than doing nothing in a lot of senses. So we really need to manage our ABCs as best as we can, but we're not, maybe a little bit of a saline bolus, but in general, if that's, it's going to cause a lot of acidosis, and that whole diamond of death thing is real. So
like 500 max.
500. That's what exactly what I was
max.
thinking. Maybe 500 of a fluid bolus with your patients, but after that, they need blood if they're bleeding out, and for many reasons aside from the fact that they're hypovolemic.
Yeah.
So,
And I will touch on this point of permissive hypotension in these patients.
Yeah.
Huge deal. It's detrimental to get these patients up to a normal blood pressure, right?
Yeah.
We want to, right, because the more pressure you add to this plumbing system, if they are bleeding, the faster they're going to bleed, right? So we, it's a little bit subjective what permissive hypotension means in the flight world, critical care world. We usually go off MAPS. So MAP is 60 to 65, somewhere in there. For probably your regular common variety 911 medic, systolic at 90, right?
Are you achieving that with like pressors or pharmacological intervention, or
It's a big debate there too.
Yeah.
There's a big debate.
which could probably be its own, probably its own thing.
Because same thing, right? If you, let's take Levophed or epinephrine, right? If you make this tank tinier by squeezing the vessels to try and get that blood pressure up, you're essentially doing the same thing as overloading them with fluid. You're making them bleed faster, right? So there's room in there for discussion of medications. You know, if I put a trauma patient on Levophed, it's a whiff. It's a tiny dose.
And you're
After
still
I've given
probably
blood.
looking with a much lower goal than you would, right? Like you're still looking at like an 80 to 90 systolic instead of a 110 systolic.
That 60 to 65 for the mean arterial pressure. If I get 67, I'm like literally, I need to go down on my Levo. Like,
Okay, interesting.
like Mike was saying, 500 max for a crystalloid bolus. I don't care if it's LR, if it's saline. It's not anything beyond that. It's more detrimental than it's helpful. The blood, you know, I'm very fortunate because my agency has labs, so we can kind of dial in our blood. But for a big trauma patient or a massive injury, we don't really need labs. Just get the blood in.
And I know there's potentially people out here like listening to this, like, oh, I don't carry blood, so I'm going to do whatever I can for that patient. Well, whatever you can for that patient may just have to be nothing as opposed to a huge fluid bolus. Because trust me, there is science, there's paper after paper that proves that is more detrimental than doing nothing.
Yeah.
So
100%.
Cool.
And that sucks to think about. Like, you don't carry blood, you're just going to sit there and watch them. Well, bro, you have other things you can do.
Yeah. And that's another thing where, kind of like you were saying, paper after paper, this blood thing and administering in the field is becoming more and more of a relevant topic. It's really being pushed hard. And there's some really cool new products out there. There's dehydrated plasma that you can give.
Mass pants. Are we bringing mass pants back?
Bring some mass pants back. So yeah, it really, it's just another, we'll call it a paradigm shift that's actively trending and being talked about more and more with all these studies that, you know, all these patients fall under the term of preventable death that could have been saved with a blood transfusion or pericardial centesis, or, you know, just this shift in how EMS is operating.
Which is kind of fun being in EMS, that we've had this big shift from, and I always like joke, like, you know, Bubba said to do this thing and we're all going to do it, to now like, no, what does science say? And so we're in this kind of revolution, I feel like, having been in this for a fairly long, you know, not as long as a lot of people, but 10, 15 years, most of us here, we have started to really be part of that shift and to see that shift of evidence-based medicine, better practices because of it, and the whys, right? Like to finish off this whole thing, this whole episode, right? We were talking about doing the whys, and it feels like EMS in general is starting to really look at the whys, and we're going to do things based off the whys, not just because, you know, Casey put a sandbag on somebody's chest when he thought they had a flail segment and they felt better. So we're going to all put sandbags on the chest or whatever. Any closing thoughts? Because we're way past time for you guys.
No, I don't think so.
We definitely need to come back. I think that'd be a fun one to talk about, like blood, permissive hypotension, and those kind of things.
Treatment of shock in general.
Stay tuned for part 2.
Cool. Thanks, guys. Appreciate you guys giving us some time coming down to talk to us. Wade,
thanks for having us.
You have to be here anyway, so
Yeah. I live here. I'll be here.
So check us out on YouTube. If not, we're on Apple Podcasts, Spotify, all that stuff. We appreciate you guys listening, watching, all of that, and we will see you next time. Thanks.